called the stress response or the general adaptation syndrome when somebody's under kind of long-term stress. The first stage is the fight or flight response, which is brought on by the sympathetic nervous system, which in turn stimulates adrenal medulla to produce epinephrine and norepinephrine. The resistance reaction, we're going to look at that in the next slide. That's the second stage. This is for longer periods of stress. When the stress doesn't, it's one thing if you run away from the bear and that you've gotten away from the bear and now you're good. That you've gotten through the first stage and the rest of it you don't have to do. But if it's longer term stress, like dealing with stress at work or stress in your everyday life, then you're going to go into that second stage of resistance reaction. If stress is high and it's long term, you can then enter the third stage, which is exhaustion. This is when your resources begin to be depleted, you're using up your nutrients, you're breaking down your muscle, breaking down protein in your muscle, which causes wasting of muscle tissue. You're getting suppression of your immune system because glucocorticoids are suppressing your immune system. You're getting some of the effects you would see in somebody with Cushing's syndrome, not to that severity necessarily, but maybe in some cases you might find an increase in fat deposition in your abdomen and things like that. You may get an effect on the pancreas and stop producing insulin, which then results in hyperglycemia, as we'll talk about. So this stress response is shown here. This at the bottom here, you'll see fight or flight response. The general fight or flight responses due to sympathetic stimulation and epinephrine and norepinephrine from the adrenal medulla. And then the resistance reaction is due to cortisol's effects, glucocorticoid effects, which respond to stress. Human growth hormone and insulin-like growth factors also have some effects. And thyroid hormone also has effects on dealing with longer-term stress. And these hormones are involved in providing energy. They stimulate the breakdown of lipids, breakdown of glucose, the conversion of glycogen to glucose, things like that. But also has effects on inflammation, the inflammatory response, which can suppress your immune system. So long-term stress, if you're doing this too long, it can have physical effects that lead to exhaustion. So if you were in a war zone and you were dealing with, having to deal with bombs going off around you, or you were in an abusive relationship or something like that, that long-term stress can cause physical manifestations, physical problems, like I showed you in the previous page or previous slide. So some of these effects is from overexposure to glucocorticoids and those other hormones. Too much of that is not a good thing. So that's why stress can have an effect on the entire body. If you look at the endocrine system, this is just showing focus on homeostasis. The endocrine system affects every organ system in the body, and stress is, as a result, stress is going to affect every organ system in the body as well, because those effects of cortisol and those other hormones are going to affect all the organ systems in the body. That's why I just put that up there. So stress can affect health. Emotions can have an effect on health because stress affects your emotions, and all that can be tied together. Any questions about any of this so far? Okay, the pancreas. So the next one we're going to look at. Pancreas is an endocrine and exocrine gland. It is associated, it's right behind the stomach. So it'll be right here behind the left side of your body, behind your stomach, posterior to your stomach. And it does have exocrine functions. It does release what's called pancreatic juice into your small intestine. But it also has endocrine functions. It produces hormones. So you actually have a couple of different types of tissue in the pancreas. By the way, the duodenum is just the first section of the small intestine. So you would have a stomach here, and the stomach empties into what's called the duodenum, which curves around here, and that's the first section of the small intestine. And we're going to worry about that later when we get to the digestive system. So if you look at the pancreas, the structure under the microscope, let's look at the picture and I'll describe all that's on those notes. If you look at it under the microscope, you would find tiny little ducts called acini. So this is where the pancreatic juice is being produced, These acini are tiny ducts that these cells are releasing pancreatic juice into. That pancreatic juice contains digestive enzymes and fluid and alkaline fluid and stuff like that. This is what's going to empty into the small intestine and help with digestion. We'll worry about those later on. What we're going to concern ourselves with are these little clusters of cells called the pancreatic islets, also called the islets of Langerhans, another name for them. The pancreatic islets are little clusters of cells surrounded by acini, surrounded by the little ducts. It's kind of hard to really see those acini in this picture, and we're not going to worry about that. But the pancreatic islets are just little islands of pancreatic endocrine tissue. And so they are a separate group of cells, separate endocrine epithelial cells. Some of them are producing glucagon. The alpha cells are producing glucagon. Beta cells, so alpha cells, and you don't have to identify them, just know the name of the cell, but alpha cells produce glucagon. Beta cells, shown in pink, produce insulin. We're not going to worry about the delta and F cells. They do, there's those hormones as well, but we're just going to worry about those two, glucagon and insulin, which you've talked about before because those are the hormones that regulate blood sugar levels. Glucagon, produced by those alpha cells, secrete glucagon in response to low blood glucose. They stimulate glycogen breakdown in the liver. Beta cells secrete insulin in response to high blood glucose levels, stimulating cells to take in glucose, also stimulating your liver and muscle to convert glucose to glycogen for storage. And also, if you have a lot of glucose, you're going to convert some of that to fat in your adipose tissue. We're not going to worry about these two, so don't worry about them. And there's tables, but again, just focus on alpha and beta cells. So here it's showing you how, blood sugar is regulated by negative feedback and how it's regulated by glucose levels. You have these pancreatic cells, the alpha and beta cells, are monitoring blood sugar levels, or monitoring how high or how low your blood sugar is, and then producing hormone in response. So let's start with, I guess, number one. If you have low blood sugar, hypoglycemia means low blood sugar. Normal fasting glucose levels are 65 to 105 milligrams per deciliter of blood. So in other words, if you fast for 8 hours, your blood sugar should be in that range. If the blood sugar goes below that, then you're going to, below, like 50 milligrams per deciliter, the beta or the alpha cells are going to secrete glucagon. Glucagon, as I said, converts glycogen, breaks down glycogen, or it stimulates the breakdown of glycogen to glucose in the liver. Also, it stimulates the formation of glucose from lactic acid and amino acids. So that's, that we saw that with the glucocorticoids as well. So glucose, you're making more glucose that way. And that then you release that glucose. This is happening in the liver, by the way. Glucose is released into the bloodstream, bringing blood sugar back up to normal, and then negatively feeding back so you don't keep on producing glucagon. If your blood sugar is too high, hyperglycemia, which is higher than this level here, if your blood sugar goes above the normal level, you're going to produce insulin. Insulin has a lot of effects, but primarily speeds up the uptake of glucose into cells of the body. Just in all the cells of your body are affected by insulin. You're also going to convert much of it into glycogen and convert some glucose to fat, which is stored in your fat cells. This brings down your glucose levels, and once you get back down to normal, that suppresses or negatively feeds back to those beta cells, and they stop producing insulin. So you're fluctuating throughout the day between, sometimes making insulin, sometimes making glucagon. You're not going to make them both at the same time, obviously. Any questions about that? Now, a lot of people, especially in this country and in other developed countries, because of diet and lack of exercise, are affected by diabetes or diabetes mellitus. And this is chronic high blood sugar levels, called chronic, in other words, long-term hyperglycemia. And high levels of glucose can damage the inside of your blood vessels, which can lead to loss of circulation. It can lead to blood or organ failure, blindness, all sorts of problems. So there's two types. Type 1, which is insulin dependent, and this is where you don't produce enough insulin from the pancreas. Type 2 is insulin independent, at least for a while, and this is due to a lack of insulin receptors. It's due to really down regulation. Remember, I talked about how if you have too much of a hormone, it often causes down regulation of receptors on the target cells. And that is the case for insulin. If you've got throughout the day peaks of high glucose throughout the day because you're eating too much sugar, eating too much food, then you're overproducing insulin throughout the day, and then eventually that has an effect on down regulation. It causes down regulation of receptors. And that down regulation of receptors leads to what we call insulin resistance. In other words, you're not responding to insulin even though you're producing it. Now in type 1 diabetes, those beta cells are the reason for type 1 diabetes is it's an autoimmune condition. It's thought that possibly it's due to, I don't think it's completely understood, but possibly due to some kind of viral or maybe bacterial infection that your body's producing antibody against, but those same antibodies cross-react and attack your pancreatic cells. It's not a well understood thing yet, but that seems to be the case. So we call this an autoimmune attack. In other words, your own antibodies, if you have type 1 diabetes, are attacking your pancreatic cells and destroying them, so you're not producing insulin. Oh, thanks, sorry about that, I didn't see it out there. Now glucose is then not being stimulated to go into your cells, so your glucose levels remain high. Some glucose is, obviously, you wouldn't be alive if it weren't. Some glucose is moving into your cells, but not at the rate it should be. You're not getting as much glucose into your cells. Also, because your cells aren't getting the glucose, as much glucose as they need, they're getting some, but not as much as they should. Not only do you have high glucose levels in your blood, you also get ketones. Ketones come from burning more fat. So while you're burning more fat, which sounds like a good thing, you're burning it at a rate that produces an excess of ketones. Now, at normal levels of fat burning, it's not a problem. You get rid of those ketones out of your body. But if you're doing too much of that at an elevated rate, then you can get what's called ketoacidosis or metabolic acidosis, because ketones are acidic, they lower blood pH, and that can be deadly. That can result in death. So ketoacidosis is one of the side effects of untreated type 1 diabetes. Now, because you've got an excess of glucose in your bloodstream, your kidneys, when they're excreting water out of your kidneys, they're also going to be, well, when they're excreting excess glucose, I should say, when they're getting rid of that excess glucose in the kidneys, water kind of follows the glucose. Because glucose is a polar molecule, it attracts water. And so when you get an excess of glucose in your urine or your filtrate, you're also getting more water in the filtrate. And then when you're urinating out that excess glucose, you're also urinating a lot of water. So one of the first signs of diabetes for a lot of people is dehydration and having, even though they drink water and they're drinking a lot of water and then urinating it out very quickly, and they're dehydrated and have dry mouth. That's one of the first signs of type 1 diabetes. Now, so the way they test for diabetes, of course, is to test the urine. So you give a urine sample, and they look for elevated glucose levels after fasting. Or they give you a sugar water solution, and then they follow how quickly your glucose levels drop in your bloodstream after you drink a sugar water solution. That's another test we're going to be looking at. And back in the olden days, before they had those tests, doctors used to actually taste the urine because it would be sweet tasting, which sounds gross, but that was the way they diagnosed type 1 diabetes, is by looking for sugar in the urine. And that's what people often call it sugar diabetes, or the sugars, but it isn't a funny thing or a good thing to have. Now, this is showing an oral glucose tolerance test in somebody who's got type 1 diabetes versus somebody who's normal. Okay, so they'll give you this really sugary solution to drink. They do these tests if they suspect you have diabetes or if you're showing any signs of it, but also they do this in pregnant women because there is gestational diabetes. Some women suffer from diabetes during pregnancy, and they'll have a woman go through this at some point in time during pregnancy, like 5 months or later. So first of all, it's showing 0 time would be when you drink the solution, and then here's milligrams per deciliter of blood glucose and insulin. So notice the person in normal is blue. So when you first drink that sugar solution, your blood sugar is going to go up, and your kidneys are going to respond very rapidly and produce a lot of insulin in response to that high sugar load. And so you get this peak of insulin. Well, then once your blood sugar starts dropping back down to normal levels, your insulin levels begin to drop. So you slow down your insulin production and get back down to nearly 0 once that glucose is at normal ranges. So notice there's not a big fluctuation of blood sugar in a person who's got normal response to sugar. But somebody who's got type 1 diabetes, notice it's like the opposite happens. Instead of having a peak of insulin, they have very low insulin levels. There may be some insulin production from some pancreatic cells that haven't been affected yet, but it's very low. And as a result of those low insulin levels, the blood sugar peaks. So your graph is all reversed for somebody with type 1 diabetes. Now, on the another type of diabetes is type 2, and obviously for type 1, the treatment is insulin. You have to constantly monitor blood sugar and either inject insulin or be on a pump that monitors your blood sugar and injects it for you. Some people have, there's different levels of type 1. Some have milder forms and some have more severe forms of it, so it kind of depends on the situation. Type 2 diabetes is one that develops over time. There can be a hereditary predisposition to type 2 diabetes, so if it runs in your family, you might be genetically predisposed to it. But it also is affected by diet and lifestyle. If you're constantly eating and you gain weight, you don't exercise, well, your blood sugar levels are going to be elevating throughout the day, overstimulating the pancreas to produce insulin and resulting in insulin resistance. Also, if you're not exercising, because exercising gets that glucose out of your bloodstream. You're using that glucose for energy. So exercise and diet can, in the early stages, can stop it. If you have type 2 diabetes or you're showing some insulin resistance early on, if you start losing weight and exercising, oftentimes that clears up that insulin resistance and your cells come back to normal and start producing normal amounts of receptors. But if you let it go too long, you can't undo it. So it's something you want to jump on if you ever have that condition. Now, type 2 diabetes is associated, it used to be called adult onset, and type 1 was called juvenile. Type 1, usually people develop type 1 diabetes as children because it's just from some kind of exposure to a virus or something in childhood. Type 2 diabetes usually develops in adulthood, but they're starting to see it more in children who are obese because the obesity rate is increasing in children, which is why it's important for children to get exercise and a proper diet because they could develop type 2 diabetes just as kids. But it's usually associated with people who are overweight. There's some people who are underweight or thin, still develop it for other reasons, probably for possibly, some kind of something going on in the pancreatic cells. But anyway, like I said, overexposure to high glucose levels due to lack of activity and too much food overstimulates the insulin production, which downregulates insulin and insulin receptors, resulting in insulin resistance. Now, type 2 diabetes, unless it's a very severe form, does not usually result in ketoacidosis like type 1 diabetes does. Now let's look at the oral glucose test. You have the time in hours from the time you drink the sugar drink, and then they start monitoring your insulin and glucose levels. Normal is the blue, okay? So again, The normal person is going to, in response to higher than normal glucose in the blood, is going to produce a peak of insulin from the pancreas, and then as the glucose levels respond and drop, then insulin levels drop back down. That's normal. Somebody who's pre-diabetic, somebody who's starting to show, this pre-diabetic is somebody who's starting to show insulin resistance. And they are going to, where are they? They're going to have an elevated glucose level, and notice that they have a higher than normal insulin production. Because they've got downregulation of receptors, their pancreas just keeps on producing insulin, trying to get a response, because the blood sugar is not responding. Your blood sugar keeps on going up. Notice how in the normal person, it goes, immediately starts dropping. In the pre-diabetic, it eventually does go down, but it takes a while because there's fewer receptors that are responding to the insulin. Now, type 2, which would be the next level, type 2 diabetes, which is the less severe early form of it. You can see that the levels of insulin are even higher, again, because of insulin resistance, and the blood sugar takes a while to respond because, again, lack of receptors, so there's even fewer receptors. Now, early on, that can be reversed by diet and exercise, but if you don't, if you continue to let this go on for a while, you get the more severe type of type 2 diabetes, where notice that the insulin levels are low. Your pancreas just shuts down. You know, it gives up. It stops producing insulin, so your blood sugar goes sky high and doesn't come down. So it's like having type 1 diabetes. Basically, some people who go for a while with type 2 diabetes have to get, this is why they have to get insulin injections, even though they don't have the type 1 diabetes, the traditional type. And basically, their type 2 diabetes has converted to type 1, and they're having to take insulin supplements to supplement that, as well as other medications that help their cells respond to insulin. So some of the medications that type 1 and more severe forms of type 2 diabetes take is they take a second medication that helps their cells respond to the insulin so that they will take up that extra sugar and get it into their, get that sugar out of their bloodstream. Any questions about the type 2 tests, oral glucose tests? So you can just look at this table on your own. It just talks about the differences between type 1 and type 2 and how they're treated. Now, reactive hypoglycemia, this is where your cells, or in some people, this is, oddly enough, this is in people who are genetically predisposed to type 2 diabetes, which seems odd, but as I said, it is genetically linked. So in those people, sometimes they have an exaggerated response to insulin, or the beta cells have, the beta cells have an exaggerated response. So when blood sugar goes up, the beta cells secrete too much insulin, and then you get over too much glucose going into your cells. You get hypoglycemia. So this is not, this would be like a very, somebody who has this happen a lot. Sometimes hypoglycemia happens just because you haven't eaten in a while, and you might get a little shaky and hungry, or you forgot to eat and suddenly you get a little hypoglycemic, or you're pregnant. In pregnancy, that baby's taking a lot of nutrients out of your bloodstream. You might get hypoglycemia when you're pregnant when you didn't before. That's not quite the same thing. This is in people who are genetically predisposed to type 2 diabetes, and this happens quite often where they get a big sugar load and then they overproduce insulin, and then they get an exaggerated response to that insulin and get and then suddenly they're shaky and hungry as if they hadn't eaten any sugar. But this is especially true if you're eating a lot of sugar. If you're eating too much sugar, you're going to get that response to that sugar, like if you drink a soda or something. You might, if you drink a soda and then get hypoglycemic shortly after, that could be reactive hypoglycemia that you're suffering from. Any questions about that? Okay. All right. Now, very quickly, ovaries and testes, we're going to talk about them later on, but they are not only gamete producers and producing egg and sperm, but also endocrine glands. The ovaries are producing estrogens and progesterone, as well as some other hormones. Testes are producing testosterone. These are all lipid-soluble hormones. And this talks about those hormones. I'm not going to worry about them right now. So, if you can read about them if you want to, but I'm going to test on these later when we get to the reproductive system. I'm not going to spend time on these, but we will talk about these hormones later on. And some other cells that produce hormones that have other functions include the thymus gland. The thymus, I guess we'll look at the pineal gland first. The pineal gland. The pineal gland is a teeny tiny little gland right here in the very back of the diencephalon region, posterior to the thalamus. And this is and it would be right about here in the actual brain, though I don't know if it's there in that picture. But the pineal gland, here's another picture of it. If you find the pineal, where's the label? There it is. This is facing the other direction. This is the anterior posterior side, so there it is. And the pineal gland produces a hormone called melatonin. Melatonin helps regulate your biological clock or circadian rhythms. You produce more of it during nighttime, during dark light conditions. So information coming in from your eyes, some of the information goes to the pineal gland, and when it's daytime and bright outside, you don't produce very much melatonin. That suppresses it. When it's dark, you produce more melatonin. That's what makes you feel sleepy at night. And so if you're having trouble sleeping, it's good to have low light and just have some lamps on. Don't have bright overhead lights on, because that suppresses melatonin. If you want to increase melatonin production, have low light conditions. Now, because of this, some people who are blind, who their retina doesn't respond to light, that information isn't going to the pineal gland, and they have problems regulating their circadian rhythms and feeling sleepy when they're supposed to. And there are now medications for people who have that kind of blindness, where their biological clock gets way out of whack because they're not getting that melatonin production at night like they should. And some people do take melatonin supplements. You just have to be mindful that you're taking a hormone, and too much of a hormone could be a bad thing. So it's better to kind of try to get your pineal gland to produce more melatonin by being in dark light. Melatonin can also be a problem if you live in northern latitudes. The further north you live, the shorter the days in the wintertime, and those people tend to produce a lot of melatonin, which creates seasonal affective disorder, which is a kind of depression where you just feel lethargic and you eat too much and gain weight. And so people like that often need to be under light, put bright light or wear light visors sometimes to help stop that melatonin production during daylight or during, for longer periods, so that they don't produce too much melatonin that makes them feel bad. Now, another gland that produces hormones, but this gland actually has other functions as well. The pineal is an endocrine gland. But the thymus is an endocrine gland, but it's also an immune system, a lymphatic system gland. It's involved in developing your immune system cells called T lymphocytes. And it produces hormones that help stimulate T lymphocyte or T cell lymphocyte maturation. So it does produce hormones for that purpose. So it's affecting itself, basically. These hormones are local hormones that are affecting that maturation process. There are other tissues as well. We're not going to worry about them until later on. Some of them we'll talk about later. For example, HCG, which comes from the placenta. This is the one they test for in home pregnancy tests. There's also hormones coming from your digestive system, your kidneys that produce erythropoietin and some other hormones. And we'll talk in calcitriol, which we've talked about. Your heart, your skin, your fat, many structures in your body that have other functions have individual cells in there that produce hormones. And we'll talk about some of those later on when we come to them. But there is a lot of hormone production in your digestive system coming from your small intestines and stomach and things like that. Finally, the last thing I want to talk about in terms of hormones are these locally acting hormones called eicosanoids. Eicosanoids are all made from a lipid, a fatty acid in the plasma membrane, in the membranes of your cell. It's called arachidonic acid. Arachidonic acid is used to make other, what are called omega-3 fatty acids, and it's also used, or is omega-6, get them mixed up. But anyway, it's used to make a lot of other fatty acids. But it is also used, this fatty acid, arachidonic acid, is used to make leukotrienes, which are eicosanoids. These affect inflammation. So these stimulate rather than suppress. They stimulate inflammation and the inflammatory response to infections and things like that. But they can also have an effect, I guess, when you have allergies or asthma. They could have an effect on that as well. Now, PG stands for prostaglandins, and prostaglandins have lots of effects. Some of them constrict or vasoconstrict blood vessels, some of them vasodilate. Some of them stimulate platelet, or I should say, some of them stimulate platelet aggregation, which leads to blood clots. Some of them suppress it. So it just depends on the prostaglandin you're talking about, but they are produced locally and they have a local effect. So wherever they're produced, they're having that effect. They also can have effects on smooth muscle contraction and relaxation. So here are some of the effects of eicosanoids. Much of this is in terms of smooth muscle contraction, relaxation, and blood clotting. That's prostaglandins. That's how you spell it. And then anything involving inflammation of the leukotrienes. But prostaglandins also play a role in ovulation and smooth muscle contraction during menstrual periods. This is what causes menstrual cramps. But those menstrual cramps happen to push the menstrual fluid out of the body. So it has a function, but it's also painful. So prostaglandins are responsible for that, and they do play sort of a secondary role, I think, in labor contractions, but that's primarily oxytocin that's doing labor contractions, but they do play a role in it as well. And if you have menstrual cramps, or if you have pain from, say, vasoconstriction of blood vessels, then a good medication to take is ibuprofen or one of these other COX inhibitors. Because what they're inhibiting are two enzymes, the cyclooxygenase enzymes 1 and 2. These are involved in prostaglandin synthesis, and which is what often leads to pain, either from vasoconstriction or which can cause headaches, or smooth muscle contraction, which leads to menstrual cramps. So what COX inhibitors do is they inhibit COX-1 and 2, or just COX-2 enzymes. If it inhibits both, it has more side effects because it has more of an effect. It's affecting more of the prostaglandins. If it only inhibits COX-2, it has fewer side effects, which is why Celebrex and Vioxx have fewer side effects than ibuprofen and aspirin. And also because these are affecting some of these prostaglandins that are anti-platelet aggregates. This is why aspirin, for example, is used to prevent blood clots. If you take low-dose aspirin to prevent blood clots, actually it's over here, not the aggregation, but this one. You're suppressing, this is a different one, but you're preventing platelet aggregation and preventing blood clots. So that's why people take aspirin for, not dissolving blood clots, but preventing their formation. So anyway, that's what they mean by COX-1 and 2 inhibitors. These medications work in reducing pain by preventing the production of these prostaglandins and other leukotrienes that can cause pain in some cases. And then finally, growth factors. These are obviously hormones that stimulate certain types of growth, specific types of growth in the body. We're not going to worry about those, but there are growth factors that are hormones as well. And we'll talk about growth factors, hold on, a little bit, not very much, but a little bit in the next section, which is on blood. Because your blood, and hold on, I got 2 minutes and I need every minute I got. Growth factors have an effect on blood cell production. So we'll see some examples of those in a minute or next time. I was hoping I'd get to more of this today, but hopefully I can cover all or most of the blood on Thursday. But you hear about the circulatory system. The circulatory system is actually two systems, cardiovascular and lymphatic. We're focusing right now on cardiovascular, and we'll focus on the lymphatic system later. Lymphatic system vessels carry lymph, blood vessels carry blood, and so that blood is circulating in your blood vessels, and your heart is pumping that blood. That's the cardiovascular system. The lymphatic system, though, and the cardiovascular system are tied together. And very quickly, here's some facts about blood. It's a liquid connective tissue. Plasma is the matrix which the blood cells are floating in. Blood volume, 4 to 5 liters in women, adult women, 5 to 6 liters in adult men. The blood temperature is slightly higher than our core, which helps keep us warm. Your blood is an important regulator of body temperature. It helps us stay warm and also helps radiate heat when we need it to do so to cool us down. And the blood pH, as I mentioned previously, around 7.35 to 7.45, so it's very slightly alkaline. You don't want it to go outside of those ranges. So we'll pick this up on Thursday. I'm hoping I can get through all of it.